Welcome to Collegial Conversations with Diana Clark, the professional webinar series that offers clinical and personal perspectives on issues that are common, but often not talked about. Here is today's Collegial Conversation.
Thank you, everyone, for joining this Collegial Conversation with Diana Clark. Today, joining Diana is Dr. Nathaniel Van Kirk. Dr. Van Kirk is a licensed clinical psychologist at McLean Hospital, specializing in severe anxiety disorders, obsessive compulsive disorder, trauma, and PTSD. Diana and Dr. Van Kirk will discuss what it is like to live with OCD and what effective treatment methods there are available for those with this diagnosis. Thank you so much for joining us, Dr. Van Kirk. I will now pass the conversation over to Diana.
Thank you. Appreciate it, Laura. Hello, Dr. Van Kirk.
Hi, Diana. Thanks for having me.
You're welcome. I'm really interested. Let's dive into what exactly are considered anxiety disorders, OCD disorders, and trauma disorders, because we throw those words around really casually. So yes. How would you define them?
Definitely. Well, I think in many ways, one of the things that's interesting about kind of thinking about OCD is it's used to be kind of conceptualized as an anxiety disorder. But now it's kind of been moved into a category in and of itself, similar to PTSD and trauma-related disorders. But when I think about anxiety disorders and everything kind of goes into it, in many ways, statistically, it is one of the most common kind of groups of disorders diagnosed. But generally, it's the idea that we all have anxiety, we all feel that feeling that we're all familiar with. But it's when the fears of anxiety, worry, those feelings of distress, they really get to a point that becomes functionally impairing for individuals, where it gets more and more difficult to do the social, occupational, or just functional things necessary that we all do have to do day to day. Where the but the anxiety kind of grows out of proportion in terms of, it's almost like a false alarm. It's kind of like if your fire alarm in your house or apartment is going off, every 30 seconds. It gets hard to distinguish on what is kind of really something that is fearful versus isn't.
So let me see, I know enough about neuroscience to be ignorantly dangerous, okay? So what that sounds like to me is that people in the throes of an anxiety episode, or somebody who lives with chronic anxiety, is operating out of more of that midbrain fight, flight, freeze, and the ability to bring it up into the prefrontal cortex is hindered. Is that right?
Yeah, I think in a kind of general sense, and it varies a little bit by anxiety disorder or in OCD and trauma, but in some ways, it's very much that kind of like overgeneralization of the fight or flight response.
Okay.
Or the fight, flight, freeze response that we all have.
That's better. Thank you. I appreciate that. So anxiety is on a continuum. You're working with people who, would you say, are really hindered or paralyzed by their anxiety?
Yeah, so my work where most of my work in OCD kind of tends to be in the intensive treatment and residential level of care. And kind of research-wise, I tend to focus on kind of what are at the end of the spectrum where like treatment, the symptoms have really taken over someone's life. And we know that with OCD, there's in about 10% of cases, there are kind of debilitating outcomes. And by debilitating, we really mean unable to care for oneself, unable to work, socialize with friends or family, in some cases, unable to kind of feed or eat fluidly and kind of drink fluids when necessary. So it can have a really kind of catastrophic outcome on someone's life in those moments.
Right. It's not Oscar Madison or Felix. It is all about how does it influence the other elements of life. Can you talk to us a little bit more about what that can look like?
Yeah, definitely. And I think it's a great question because I think OCD in many ways is somewhat misunderstood. There's definitely been a great increase in awareness of OCD, I'll say, especially more kind of in the media as well, some good, some bad. I think a lot of times what comes to mind first is kind of fear of anxiety of like germs, contamination, and hand washing. But that's only a very small part of it. Mm-hmm. So OCD is one of those, and the reason I love working with OCD is it's one of those sets of symptoms that is so heterogeneous, it can take almost any form. It's only limited by someone's imagination. But we do know there are four main domains. The first is the contamination and washing and like fears of getting diseases or contaminants, things like that. And then the other one that we tend to see as our second dimension is a fear or responsibility for harm. So being afraid of being responsible for causing harm unwittingly to someone else, or because someone wasn't careful enough, that maybe someone they care about, someone they love may die, may be in an accident, may be harmed because of something they did or something that they weren't careful enough about. Then the third, one of the other domains, and I'll come back to the third domain, but the fourth one is another one that we see a little bit more frequently, which is order and symmetry. But another part of that is perfectionism and not just right experiences. And this is one that I think gets misdiagnosed a lot. It's the idea of something kind of being just off or not quite right. And because it's off or not quite right, it might be that something catastrophic may happen, or a belief that I can't move forward until I get rid of this feeling, because it just won't allow me to do what I need to do unless I get rid of it.
Right.
I always equate it to when you lay down at night. I think it's something that all of us can kind of relate to, is like when you lay down and you feel like, oh wait, there's something I forgot to do. It seems really important and I have no clue what it is.
No idea.
And maybe it just something feels off and you're not quite sure what that is.
Or when you start the car and you're a half a block away from home and you go, did I? And you go through the checklist.
Exactly.
Imagine that.
One of the other ones that I think is actually really important to raise awareness about, because it tends to go not talked about as much, is the dimension associated with sexual, taboo, religious, or inappropriate thoughts or images that someone struggles with. And the thing that I think is so important to talk about this one is that we know from a lot of research that everyone has these thoughts. That if you pay close enough attention to your thoughts, we all have thoughts that pop in that are like, ooh, that was weird.
Oh, awful. Yeah.
The challenge with OCD is that in those moments, an individual struggling with OCD will say, well, why did I have that thought? What does it mean about me that I had that? Does that mean I'm a danger to those around me that I love? And will literally consume their life in an attempt to try to protect themselves or those around them, or to make sure they're not a danger to others. And I think that's really the crux of this piece of OCD, is it tends to latch on to things that people value and kind of distort them. And then you get the kind of rituals or compulsions that are associated with trying to gain certainty that this feared consequence or this thought won't come true. In some way gain like 100% certainty that everything will be okay. But we know that in life, 100% certainty isn't something we really ever get.
Maybe math. Maybe if somebody who knows how to do math is doing it. I don't.
Yep. So, my answers always come out wrong. So I've given up on certainty in that domain.
Certainty with numbers. Exactly. So do you have a personal story that brings you to doing this work?
Definitely. So I actually got into this work. Initially, I wanted to go to business school and do the MBA route at the age of 14. I don't know what 14-year-old decides that like an MBA is their primary route, but a little bit after that, I actually ended up getting diagnosed with OCD. Mine started out as contamination and over time grew pretty quickly and morphed to a lot of different types. So I had intrusive thoughts, scrupulosity or religious obsessions, fear of causing harm, especially when I started driving, a fear that every time I hit a bump, that I was running someone over and didn't realize it. And so I spent a lot of time driving in circles, trying to make sure I didn't harm someone. But over time, it actually grew pretty significantly. I think at its worst, I was usually washing my hands about 3.5 to 4 hours at a time and taking 2.5 to 4 hour showers for the contamination symptoms. Then I had a myriad of checking rituals due to the fears of harm, the intrusive thoughts, those type of things. And it was as I was going through treatment that I kind of decided that I wanted to pivot a little bit and actually kind of, instead of focusing on MBA, get a PhD in clinical psychology to focus on treating OCD, raising awareness about it, and then also working on kind of those subset with a subset of individuals who kind of the standard outpatient level of care hasn't necessarily been helpful yet.
I like your word yet. Why do you use yet?
I'm glad you picked up on that, because that's one of those important questions, is that we know that the treatment works. We have tons of great research that exposure and response prevention, acceptance commitment therapy, kind of CBT-based approaches are highly effective in treating OCD. We also know that they're incredibly difficult and challenging to do, because you're essentially asking someone to face their worst fear every day, every hour of the day, and not do anything that they used to do that brings them comfort or a sense of safety. So essentially you're learning to face your worst fears that your mind can throw at you. And what we do know is that even for those that don't necessarily benefit as much as they would ideally want to from outpatient therapy, that intensive and residential level care for that subgroup is also highly effective. And so we know that we have a good core treatment that has a lot of research empirical basis to it. We also know not everyone knows about that treatment. It's not as widely disseminated as we would hope during training. And we also know that for some, they might just need a little bit more time or a little bit more intensive treatment, or help if there's, a lot of times OCD doesn't exist alone, might be struggling with depression or other things. And so we may have to also kind of make combined treatments or tailor them to each person, kind of using the research as our guide. But we know that that can be highly effective. So that's why I tend to say not yet.
Not yet. I use that when I'm talking to people about people getting well with substance use disorders. It's yet.
Exactly. Everyone, it comes in your own time, right?
Yeah.
Especially if you're asking
a lot of co-occurring between substance use disorders and OCD and anxiety disorders.
Definitely. There's been a lot more research on it in the PTSD, trauma, and substance use and dual diagnosis literature. But what we're realizing is it is becoming an emerging area in OCD, and one that presents a unique challenge. Because unfortunately, a lot of times substance use programs will kind of request someone go get treatment for their OCD because it might get in the way of kind of standard substance use practices. And at the same time, substance use can actually make it really difficult to engage in ERP. And so I think for many of the individuals who have both, they kind of find themselves in limbo, which is a really unfortunate piece and something that I think as a field, especially in the OCD community, a lot of focus has been on how do we fix that? Similar to how PTSD and substance use did such a great job with dual diagnosis tracks.
Yeah. You used a word that I had not heard in a very scrupulosity. Did I say that correctly?
Yep.
Thank you. And that is obsessive thoughts about spiritual and religious practices, basically, or thought?
Yep. Exactly. Yeah. It's a kind of any OCD symptoms that latch on to like morality or hypermorality, spirituality, and faith. And I think what's important is that even for the individual, they may not even identify themselves as highly religious or spiritual, but it's, again, that aim for certainty of essentially, what if I do something wrong, or what if I'm wrong? What if I accidentally offend someone or do something immoral without meaning to? What does that mean? And how can I prevent that? But that's essentially what scrupulosity is religious-based or faith-based OCD symptoms.
Got it. Some of the most heartbreaking stories I have heard from people who have called to seek services are frankly people with OCD, because their brains are telling them how horrible they are. These cases, these were thoughts of harming others. And it was unbelievably painful to hear this man's anguish about his thinking.
It is one of those, I think one of those disorders where you don't realize how much pain someone's in, most of the time because they don't want to talk about it. Also because a lot of their time is spent trying to prevent it. And it really does take over one's life. It is torturous in many ways. And in many ways, the things that individuals, those people say to themselves while they're going through it, assuming, not knowing what these thoughts are, essentially it's losing trust in yourself and in your mind, which can be a terrifying experience.
Yeah. So your OCD, back to your personal story, came on quickly and with a vengeance, it sounds like.
It did.
How about the healing? Is that also quickly and with a vengeance?
I wish I could say yes.
I'd like the real. Yeah.
Yeah. Unfortunately, no. It took many years. I got very fortunate that my family kind of noticed it really quickly. Actually, my mom was taking a clinical psych college class and kind of noticed it at one point and had someone to go ask, and they kind of identified it, which was great because it got me into treatment. Unfortunately, my treatment was a pretty long road. I'd say by the time I was truly kind of moved past my OCD in that sense and was kind of in recovery, was really probably mid to late college. Up until that point, I became much more functional during college, especially, and I was able to live my life, but there was still a lot of anxiety there underneath the surface. I learned how to manage it, but it was still, I was still kind of engaging and practicing my skills and strategies in ERP kind of every day. So it took quite a while. And I think that is a common experience. Part of it is because we know that data-wise, about 34% of individuals with OCD actually get misdiagnosed. I was very lucky that I didn't have that experience, but it also usually takes around 7 years to get adequate treatment. And so even when someone gets adequate treatment, then the long road starts. I'd say for myself, I was very lucky. I got into treatment pretty quickly. I did go through a number of different treatment providers over the years till I found someone who really, I feel like, understood ERP and was able to kind of help.
Can you stretch out ERP? I know it. Exposure.
Yeah, exposure and response prevention.
Prevention. Got it.
That's really the gold standard treatment for OCD right now.
Okay.
When I was going through treatment, actually, one of the reasons I got into the field is because I was kind of identified as someone who was treatment refractory. And kind of the message that I got early on was I'd be pretty lucky to actually do anything. And I should really kind of adjust my goals accordingly. And I was somewhat of a stubborn teenager. And I think that kind of actually in some ways gave me the motivation that I needed. Evidently, I told them that I was going to switch fields and do this job better. In hindsight, I was probably pretty, I was struggling with a lot and I was probably lashing out a little bit in that sense. But in a sense, that's what got me into the field. Luckily, I love what I do. Otherwise, being a stubborn teenager could have got me into trouble. Right. But in this case, it gave me the motivation to kind of really push through that treatment and what led me into the job that I do now.
So a lot of what exposure response, ERP, and ACT is about creating new neural pathways, correct?
Yeah, I think that's a byproduct of the treatment. Is OCD in many ways is learning, right? You're learning these behavioral patterns and that the reinforcement that comes with doing something that makes you feel better. ERP and ACT is all about kind of finding new, more functional behavioral patterns, even though that anxiety still exists, it's still there because we all have it, can't get rid of it. And so in a sense, we learn to manage it more effectively, face fear more effectively, and build trust in ourselves and our ability to tolerate those feelings, tolerate the uncertainty around those thoughts, and still do something that's value-driven, that's important to us, and live our life.
Right. I'm struck by the similarity of our conversation in many ways to somebody who is describing body dysmorphic disorder. Would you put them in the same pot in some ways as well?
Yes. So that's a great question because body dysmorphic disorder is actually considered part of the obsessive compulsive spectrum disorders. So OCD and its kind of spectrum disorders are now their own kind of category within diagnoses because we know they share certain similarities and their treatments share certain similarities. The other ones that go with that are excoriation or skin picking, hair pulling and trichotillomania. So both of those also go in that category, and then hoarding disorder.
And the response, the treatment involves dismantling the safety response, right?
Exactly. And that is probably, I would say, the most important part of good treatment for OCD spectrum disorders is really the ritual prevention. The goal is to kind of learn that the rituals and those behaviors that you've been using over and over again to feel a sense of safety or certainty or less distress aren't necessary for the anxiety or the distress to go away, and that you can actually tolerate it without them. But I think the key piece I always tell people when we talk about treatment is if you're doing exposure, but not doing ritual prevention, you're kind of just practicing your OCD because you can do the perfect exposure. But if someone isn't able to do the ritual prevention yet or doesn't know which rituals to resist doing, it's just reinforcing that OCD cycle. And so I really think that that is really one of the most important parts.
More detailed example of what that would look like. Somebody who's, yeah.
So I can use myself in terms of like the fear of harm, right? So part of my exposures would be driving my car around bumpy roads and then the rituals that I'm trying to resist is when I got triggered and I had that feeling like, what if I hit somebody? I'd want to check in the rear view mirror. I want to check my mirrors. I might want to stop, get out and go look at that area of the road, go look at my car for any signs of damage that I hit somebody. At times I would take pictures of it. So I could kind of come back to it later. And that was like a shortcut I tried to do to try to make ritualizing more efficient, if you will, which I later realized really wasn't doing me any good. And so in this example, it'd be going and driving, hitting bumps, hitting potholes, and purposely resisting the urge to look in the mirror to stop and look at my car when I got out of the car. I had to kind of shut the door and walk away without looking at it or taking a picture to see if I'd caused any damage. I would also make sure not to like turn around and drive over that same area.
That's hard.
It is, and
Really
especially
hard.
when it comes to harm.
Especially when it comes to harm, because the thought that you hit somebody didn't initially get dismantled, I would bet.
And it sticks around for a little while. And so that's where some of the other exposures come in, of writing scripts about the feared outcome, trying to, essentially, I always think of it, I like to give the example of, I'm not really sure where this came from, like a kid with a beach ball at the beach. Like if you give a little kid a big beach ball, one of the first things I like to do, right, is like put it in the water, and the further you push it down, the harder it pushes back. And so like, for a while you can kind of hold it at bay, but then when someone yells like, hey, pizza's here or something, kid gets distracted. And like you just kind of motioned, all of a sudden that beach ball pops back up. The further you push it away, the harder it hits you in the face. The way I like to think about ERP is it's kind of about picking up that beach ball outside of the water and staring at it. Because out of the water, it doesn't have a whole lot of force. And then you're just kind of staring at it and squeezing it until it has no air left. Because at that point, it's there, but it doesn't really have any power. And that's sort of what you're trying to do with ERP by resisting the rituals, is you're just picking it up and looking at it and facing that fear head on and building trust in yourself that like, okay, I can trust myself and not these obsessions that are looking for 100% certainty, but I'm going to practice trusting myself in these moments when I'm distressed anyway.
It's beautiful. Do you still experience symptoms that you deal with on a recovery basis?
Yeah, I think that the thoughts, and I think an important part to understand with OC is the goal isn't to get rid of the thoughts, because they're normal thoughts. We all have them. And so, yeah, the thoughts are definitely there. There are times that one will catch me off guard and I'm like, oh, that's a familiar feeling. I'd say on a day-to-day basis, my OCD symptoms don't cause me distress. I don't really feel stuck in them in that way. And there'll be stretches of time where I'll go with kind of forgetting what it was like to experience living with OCD. And then there are times where like maybe I'm, pulling all-nighters, or I'm working a little too much, or things like that, where I'm not paying attention, where it'll pop back up, pop out of the water and hit me right in the face.
I'm here.
Exactly. And then to me, those are those times where I'm like, oh, okay, I recognize this feeling. I know what I'm not supposed to do, even though I have the urge to. All right, if it sticks around, time to use those skills again, knock it back down, and then keep moving on with my day-to-day. But I'd say the thing I always like to tell people is that recovery is possible, because you're not trying to get rid of the feeling, the anxiety, or the thoughts. You learn to relate to them a little bit differently. It's okay that they're there and they don't have to dictate your life. You can still do things that you love.
Right. I like that. Well, anything you'd like our audience to know about that we haven't covered today?
I think we covered a lot of great points. And I really appreciate you kind of having me on to do this and talk about it, because I think if there's one thing I could tell everyone is that recovery from OCD is possible. It's important to know what the goal is, that the goal isn't to get rid of the thoughts, but to relate to them differently. But there is a life after it. And for providers that might be watching, and for individuals that maybe are struggling with something, they don't really know what it is. But the idea that with OCD, those obsessions or those unwanted, distressing thoughts that they can cause anxiety, disgust, guilt, feelings of shame, all sorts of things. But that it's not just hand washing and order, which I think is what people first come to. But there are so many different ways it can present, and if you're struggling with intrusive thoughts that you're not sure what to do with, or that are causing distress and are interfering with your day-to-day life, go ask. Go find a therapist who's trained in OCD, have an assessment. And because if it is OCD, there's great treatments available. But I think a lot of times people will kind of hold off asking out of fear for what happens if I tell somebody about these thoughts. Mm-hmm. But we all have them. If they're getting in the way, there's ways we can help you move through them. Right.
I had my godson say to me when he was pretty little that he thought he had OCD. And I said, why? And he said, well, because I count constantly. Mm-hmm. And I said, when do you count? He said, when I'm walking, or when I said, do you get where you're going? He goes, yeah. And I said, then you're okay.
Yeah, one of the things, kind of a final piece I can share that I think is always an interesting way to think about it is a lot of OCD rituals, they start out as functional behaviors. They just kind of get moved. All behaviors are on a continuum, right? They just get moved to this really extreme, rigid end where you essentially have to implement them in a very certain, extreme, repetitive manner where they're no longer functional. And so the goal is to kind of be able to learn to use them adaptively and flexibly and not in a ritualistic way.
Right.
But things like counting, sometimes we all find ourselves like walking up the stairs and just counting if we're thinking in our head. The question is there the need or urge to do it to prevent an obsessional fear from coming true or to neutralize a feeling? And is it getting in the way of functioning? And that's really the question to ask. So I think that's a great example.
Great. Well, thank you, Dr. Van Kirk. If you have questions, please feel free to email me, dclark@O'Connor Professional Group. And I look forward to talking with our next professional in another collegial conversation. But this one was really great. Thank you.
My pleasure. Thank you so much for having me on.
Thank you for joining this webinar. Tune in to more webinars and sign up for our newsletter at o'connorpg.com.